Dr. Rowe.
Thank you, Mr. Chairman. I'm glad today that we're having this hearing. I very much appreciate it. Since this bill was introduced in the House on June 26, 148 or so days ago, 2,960 service members and veterans have died by suicide. There's undoubtedly a lot to discuss about this bill today, but I want to ask all committee members and all of our witnesses and all of those watching not to lose sight of that number, 2,960. That 2,960 families that won't have all their loved ones around for their Thanksgiving tables or Christmas this year or ever. That 2,960 lives are forever lost. That's what this bill is about, finding the lost and saving their lives. The stakes could not be higher. Of the 20 service members and veterans who die by suicide each day, 14 did not seek care from the Department of Veterans Affairs in the 2 years prior to their death. We do not know much about those men and women except they are not VA users. Some of them aren't eligible for VA benefits and services. Others likely unfamiliar or uninterested in them. The IMPROVE Act would give VA the means to identify and support those veterans, the ones who don't, won't, or can't seek VA out for themselves, by assisting the organizations and entities caring for them in their communities so that the VA can meet them where they are and offer them whatever help they might need to save their own lives. There are precious few things Elizabeth Warren and I agree on, but we're both co-sponsors of the IMPROVE Act. We're joined by more than 200 of our colleagues in the House and more than 27 of our colleagues in the Senate. With widespread bipartisan support that this bill has received from representatives and senators across the political spectrum is rare and evidence of both the seriousness of the impact the national suicide crisis is having on our nation's veterans and the wisdom of the broad public health approach to suicide prevention the IMPROVE Act embodies. The IMPROVE Act would significantly expand the reach of VA suicide prevention programs and give more veterans the opportunity to be indirectly served by VA and to learn about VA benefits and services they may be entitled to. It would also provide a necessary mechanism to deliver care and supportive services to veterans who are at risk and who are living outside the VA's influence. It's not a threat to VA, much less to the health and well-being of our nation's veterans, as some have alleged. It's a lifeline. As you know, we will hear shortly from Blake Bourne with the Veterans Bridge Home, one of my fellow Army veterans. No single entity can adequately meet the needs of every veteran in every community in every instance. Not even the second largest department in the federal government with a budget and staff that grows every year. Because the IMPROVE Act is based on a legislative proposal in the fiscal year 2020 budget submission, specific funding has already been allocated for it in the department's FY 2020 budget request. That funding would comprise far less than 0.5% of the total mental health budget, and yet it has the potential to reach 70% of service members, veterans, who die by suicide every day without being known to the VA. Mr. Chairman, after last week's roundtable, which was very good, I might add, you asked that I draft a compromise proposal that addressed the concerns that have been raised by you and others about the bill as written, especially with regard to provision of clinical care, the provision of temporary cash assistance, and provision of grant funding to direct service providers. I believe the draft proposal I produced and shared with you and our witnesses preserve the life-serving intent of IMPROVE Act as introduced and effectively addresses those three areas of concern by, number one, putting specific mechanisms in place to connect veterans with VA medical facilities so that, if possible, any ongoing care a veteran requires is provided by VA. Two, allowing grantees to assist veterans struggling with common risk factors, but prohibiting them from providing direct cash assistance to veterans and their families. And number three, requiring VA to prioritize grant funding to so-called hub organizations, but not limiting grants only to those organizations which do excellent work, but may not effectively serve at-risk veterans in rural or remote areas where I live. My compromise language is truly a compromise. Accepting it would require concessions from both of us, Mr. Chairman, and it includes many of the suggestions that were made during our roundtable last week by our Veteran Service Organization partners. I look forward to discussing that language today and hope that we can soon come to an agreement on it and commit at last to marking it up as soon as we return to D.C. in December. I'm grateful that Secretary Wilkie is with us this morning to participate in the discussion, as his leadership and foresight on the IMPROVE Act has been steadfast. I'm also grateful for the many VSOs who are testifying here today, and those who have submitted statements for the record, and those who appeared at our closed-door roundtable just last week. Their input and support are invaluable, and I appreciate their willingness to engage with me and my staff to make sure that we are on the right track with respect to this bill and all of our work. And I'm also grateful to Mr. Bourne for being here to discuss the great work that the Veterans Bridge Home does for veterans and their families in North Carolina, and the wonderful life-saving opportunity that we have with the IMPROVE Act to sustain that work across the country. And just, Mr. Chairman, a couple of comments and why I want to do this and why I think this is important. We've had accountability, we've had metrics, we have call centers, we have quality measures, we have all those things. And guess what? Still today, 20 veterans are going to commit suicide. So we have to reach out and try to find those 14 who never get to the VA, never get the care. And I know as a clinician, if I'm seeing someone in extremis, I'm going to worry a whole lot less about when I get paid than to take care of that person in need right then. We do it all the time in healthcare. We take care of the patient and then figure out who all gets the money. And I think certainly with this small amount of investment, it's not a large investment. I agree with you on that, and the money is in a different silo anyway. But we've gone from $2.5 billion in 2005 to a $9.5 billion budget, and our suicide rate is exactly the same. We have to start doing something differently. And with that, I yield back.